Howdy, y'all. It's Dr. Jeff Jarvis, and I want to talk about one of my favorite topics, and that is research papers. I am going to share with you my top picks for the top papers of 2020 and 2021, aka the year and a half that COVID ate. Let's get right into it. First off, a little cardiac arrest here, shall we? In a patient with cardiac arrest, should we stay or should we go? Now, the main reason I brought this paper up, one, it's a great paper, but two, it gives me a chance to ask that question. And because I am such a massive fan of The Clash, I'm putting that song in your head. Don't you dare tell me that it didn't stick in your head. I know it did. Enjoy a little combat rock from your buddy Jeff. So, cardiac arrest, should we stay or should we go? What the hell does that mean? It means, should we work the patient where we found them, or should we throw them in the back of the ambulance and get them to the white palace of the emergency department that has all the resuscitative things, all the resuscitative experts, everything that is needed to save that patient's life? What should we do? So what was this study? So this was a secondary analysis of the rock epistry, and the epistry is just a collection, a registry of all of the data collected in rock trials of cardiac arrest. So a lot of great data, well-validated data that was collected during these various RCTs. They looked at data from 2011 to 2015 and performed a time-dependent propensity-matched study comparing those patients who had transport to the hospital without ROSC versus those who worked the code to conclusion, either field termination or field ROSC. And their primary outcome was survival to hospital discharge, with a secondary outcome of neurologically intact survival. And just to go over what time-dependent propensity analysis means, they looked at the two groups that were in both conditions, rapid load and go versus stay and play, and they tried to match them. 65-year-old witnessed arrest VFib in this group, 65-year-old witnessed arrest group in VFib arrest in this group, and they paired those up, and that's how they compared them. It was their attempt to deal with confounding variables. So that was the approach they took. Decent methods. Still not an RCT, but decent methods. Bottom line, what did they find? There were the majority of patients were worked on scene until they either got ROSC or terminated. So that was around 18,000 patients. And around 9,500 patients they transported before ROSC. Bottom line, what was the difference in survival to hospital discharge? It was over twice as high if you stayed and played. So on-scene resuscitation, 8.5% versus 4% with transport before ROSC. Now remember, this is all comers. We're not, if you've heard of, say, the Seattle system with a 60% survival from cardiac arrest, just remember that is 60% survival among those patients with a witnessed cardiac etiology with VFib. So it's not all comers like those with a systole. This is all comers. 4% rapid transport, 8.5% on-scene resuscitation. That is a statistically significant difference. As a matter of fact, it's an adjusted odds ratio, meaning an odds ratio after adjusting for all the potentially confounding variables of 0.8. So 0.48 adjusted odds ratio if you load and go. What does that mean? So if you put that in context of percentages, it means a 52% decreased odds of survival with load and go. Now that's just survival of any flavor. What about neurologically intact survival? Same concept, 7.1% neurologically intact survival if you work it on scene versus 2.9 if you don't. And that was an adjusted odds ratio of 0.6, or a 40% decreased odds of functional survival with load and go. Now, this is a great slide, and I really want you to take a look at this. What this is looking at is the relationship between a system. Remember, this is a multi-system study, and it looks at each system and plots the proportion of their patients that got transported without ROSC against what their survival was. So in Group A, for example, Site A, they had around 4,800 arrests, and they transported almost nobody without ROSC. So 0% intra-arrest transport. Their survival was almost 20%. On the other hand, if you look over at J, with 873 arrests, they transported over 60% of their patients without ROSC, and their survival is around 5%. Now, if you look at this and say, I want to just draw a line that hits most of these points, you're going to get a linear decrease in survival. So as intra-arrest transport without ROSC goes up, survival drops. Bottom line on this study, should we stay or should we go? Well, if you value a 40% increase odds of neurologically intact survival, stay and play, finish it on scene, either get ROSC or terminate the resuscitation. I think this is important information. Great paper. Okay, so that is addressing where to do the things. Let's take a look at the things themselves, starting off with airway management. Think back to the PART study, which is one of my top papers from several years ago. It compared in a randomized fashion endotracheal intubation versus King LT and found 2.9% increased survival with the King LT. Now, the big question is why? Why? I want to know why. Why was there more survival with the King LT? Well, there are a couple of thoughts. One is maybe it has something to do with the 51.6% first pass success with intubation in PART. In other words, intubation performance in PART was really bad. 51.6% intubation first pass, 90% King LT first pass. Was that it? Well, maybe. We'll take a look at what the evidence says. The other issue is maybe it was compression interruption. Maybe you just interrupted your compressions more with intubation than you did King LT. First off, let's take a look. Was it that 51% first pass? So this was a study. It was a secondary analysis of the PART trial. And what it did was took a look at the PART data again and ran an adjusted odds ratio, so the logistic regression, basically looking for the association between multiple variables. And it added all of the variables, age and bystander CPR and initial rhythm, and the type of airway, intubation versus King LT, but it threw in there a new variable. It wanted to control for first pass success. And what they found is that first pass success was associated with improved ROSC, but no other outcomes, no meaningful outcomes, like in the case of PART 72-hour survival, and also there was no difference in neurologically intact survival. So this paper would suggest maybe not. Well, what about changes in compression quality? Now that's a definite possibility. This was another study that was a secondary analysis of PART, and it looked at just those arrests that had CPR metrics, so that was using a CPR puck, and we know about compression rate and interruption. And what they looked at was the difference in CPR quality between the intubation group and the LT group. And what they found is there were more interruptions with the intubation group than there were with the LT group. They found that there was longer interruptions with intubation than there was the LT group. Now, they did say if you look over the entire code, the entire duration, the compression fraction was no difference. And if you remember the compression fraction, that is the proportion of the time you should be going pumpy that you are going pumpy. So this paper suggests that maybe the difference really was compression quality. But not so fast on that whole first pass success thing, because I kind of have some issues with how that analysis was done, even though I was an author on that paper. So they just looked at first pass success with any device and to see whether that was an independent predictor. But the first pass success with King LT was high. It was 90%. And it was really low with intubation. And it almost seems to me that maybe there was some confounding variables that maybe we're actually measuring the same thing and missing the actual question. Well, the folks at the Seattle Fire Department looked at their data from their CARES registry, And they, I think, did a better analysis of this question of what is the association between first pass intubation success and outcome. Now, this was not a randomized controlled trial, so we can only show correlation here, not causation. So this is not definitive. But if we want to be honest with ourselves, we ain't going to get a randomized controlled trial of first pass success versus not. It is not ethical to intentionally miss an intubation. We're never going to see that study, so this may be the best look we get. So what did they do? They looked at their overall survival and calculated that. This is all comers, asystole, VFib, everything. And they saw an 8.1% overall survival. And then they took all of those arrests and they broke them up into buckets. This bucket is those who were successfully intubated in 1 attempt versus 2 attempts versus 3 and 4 or more attempts. And they calculated the survival in each bucket. So remember, the overall survival across all buckets was 8.1%. First pass bucket, it was 10.8%, so higher than overall. So if survival with first pass success is higher than overall, then not first pass success is going to be lower. And indeed, that's exactly what they found. Survival, if it took you 2 attempts, was 4.3%. 3 attempts, 2.6%. 4 or more attempts, only 2% of those patients survived. So what we see is survival, first pass success, 10.8 drops to 4.3, then 2.6, then 2. So you see a really steep drop off at first pass success. Now, they looked and they calculated an adjusted odds ratios for survival with each additional intubation attempt. And they found an adjusted odds ratio of 0.41, which means a 59% decrease in the odds of survival with each additional intubation attempt. Now, that was neurologically intact survival, but they did look at other measures. So survival to discharge, ROSC, they showed exactly the same thing. And they also looked at this stratified by the initial rhythm. So maybe first pass success only matters in VFib arrest. Or maybe it only impacts non-shockable rhythms. And it turns out no difference. It didn't matter. First pass success is a big deal regardless of the rhythm. Great paper so far. This may be my favorite paper of the year. This is so impactful for me. I'm repeating this analysis with my data. My system right now has a higher first pass success. We're around 90%. And because of that, I've had a really difficult time knowing what to do with the results of PART. But when I analyze my data and compare first pass to second pass, because we only allow 2 attempts, if I see the survival rate between first pass and second attempt drops off anywhere near what they saw in Seattle, I'm going to limit our attempts to just 1 before going to a supraglottic. So, great paper. Dr. Murphy, colleagues, strong work. So that's Airway. Let's get to something a little more shocking, shall we? Dual sequence defibrillation. This is the Dosevf Trial. So the concept here is if 1 defibrillator is good, 2 must be better. At least that's the assumption. We know that there has been a pretty good uptake in the practice of dual sequence defibrillation in the field and in the emergency department, largely based on the study of a series of patients, so a case series that was done in Wake EMS, and they showed that they were more successful at breaking VF with 2 defibrillators versus just 1. And it's not all on Wake. We have seen other data from this. We've seen in-hospital data from cardiothoracic surgery that suggest it may work. Well, then we started seeing some observational data that had huge confounding biases that said no difference in survival with dual sequence. So the trend now started going, hey, don't do that. I always thought the hey was kind of premature. And if I'm honest, the adopting was probably premature anyway. But the rejecting, I think, was particularly premature given the confounding issues in those studies. So what we needed was a randomized control trial. That's exactly what we're going to get. So this paper was called Double Sequential External Defibrillation for Refractory VFib, the Dosevf study. Now this is a pilot study, and that's really important. So don't have any take-home conclusions from what I'm about to show you, but I do think it is very informative. So they are going to run, or are running, a randomized control trial of 3 groups. So they are randomizing patients with an initial shockable rhythm to either standard care, which is 1 defibrillator, 1 shock at a time, normal ACLS protocols. So that's standard. The next group is dual sequence defibrillation. So they have an anterior lateral pad and they have an anterior and posterior pad placed. Now, one thing I want to point out here is the posterior really means posterior for a reason. Put it on the back. You have to roll the patient to get that on there. And it sounds like that's self-explanatory, but I've seen an awful lot of dual sequence defibrillation where it's anterior and lateral and maybe a different anterior and a slightly different lateral. That's not really doing anything. That's just increasing the voltage, and we don't think necessarily that that's what's doing this. All right, so 3 groups, standard, dual sequence, and then the third is vector change. So they just go from anterior lateral to anterior posterior, but are still just doing 1 shock. So they're going to run this and see if there's a difference in neurologically intact survival. But that study is still going on. This is the first part of the study. It's a pilot study. It's a feasibility study, and they just want to know, as they should, they're kind of working the kinks out, can they deliver over 80% of the shocks in the group that they're supposed to give it to? Reasonable study. In other words, can they get this thing done? Is it reasonable to do? Now, one other issue here is they need to make sure it's safe. They need to make sure using 2 defibrillators doesn't cause patients to spontaneously combust. But there has been some murmurs driven, in Jeff's humble opinion, from the legal departments of monitor manufacturers and maybe from the warranty departments who are trying to get out of paying on warranties that say, no, if you use dual sequence, you're going to fry the flux capacitor and our monitors are just going to be worthless. So even though the engineers at those companies are greatly insulted that you think something like that could hurt their monitors, they kind of have a pretty good understanding of how electricity works. So even though that's the case, we want to see, were patients or monitors hurt in this trial? All right, so what did they find? First off, just as you would expect, they absolutely can do this study. 77% of patients got the correct shock as randomized by shock number 4. Now, it is important to realize by shock number 4, they just did 1 shock on the first 3 shocks. So the entry criteria, they randomized them after that 3rd shock. So 77% of people got their randomized group on the first shock, which is pretty impressive considering they had to bring another unit in. No patients were harmed, no monitors were harmed. Turns out maybe the engineers know more about electricity than lawyers. Just a thought. But that's not what we want to know. Okay, yeah, we do want to know that they don't blow up. They don't blow up. Got it. We want to know, does it get people out of VFib? Does it improve survival? So I'm showing you the preliminary data. They did not even perform statistical tests on this because they said about 13 times, appropriately so in this paper, this is preliminary data, don't draw conclusions. Yeah, I won't draw any conclusions. I get it, preliminary data. What did you find? I want to know. Thankfully, they told us. In the standard group, 67% of patients had VF termination versus 82 in the vector change and 76 in the dual sequence. ROSC also higher with both the vector change and dual sequence, and ROSC sustained at ED arrival, also higher with vector change and dual sequence. So even though I agree this is all preliminary data, it is enough data, I think, to say, hey, there's a hint here. Maybe don't throw the baby out with the bathwater yet. Once they do the trial, if it says there's no difference, then you can throw the baby out. Let's talk TXA and brain injury, shall we? So we know from CRASH 2 that TXA decreases mortality from hemorrhagic shock in trauma patients. But they weren't looking at brain injuries. And we know from CRASH 3, which was looking at brain injuries, that there was no difference in mortality with TXA and brain injuries. But one of the things that we found in there is there's a bit of a Goldilocks effect when it comes to TXA. If you have a patient who gets hit in the head very lightly, like that, they have no loss of consciousness, they have a GCS of 15, they have no blood in their brain, they are going to do fine no matter what you do, TXA or not. So there's no way TXA can help in that group. So mild TBI, concussions only, no way TXA can benefit, and that's what CRASH 3 found. On the other hand, if you have a massive head full of blood, your brain has already herniated down and it's now in your neck, no amount of TXA in the world is going to fix that. The damage is already done. So if you're too severe, TXA can't work, and that is also what CRASH 3 found. However, in between, you have a significant brain injury, but you're not dead yet. Maybe TXA can have an impact, and there was a signal in CRASH 3 that that was the case. So that's what this trial wanted to look at. And this is the RAL study, and the title here is Effective Out-of-Hospital Tranexamic Acid versus Placebo on 6-month Functional Neurologic Outcomes in patients with moderate or severe traumatic brain injury. So what did they do? What did they look at? This was a 3, not 1, not 2, but 3-armed, double-blind, randomized control trial. Double-blind meaning the patients don't know what they're getting, the provider doesn't know what they're getting, the only person that knows what they're getting is the pharmacist who mixed the drugs and labeled it. All of the calculations are done on this, basically just knowing that they were in group A, B, or C, but not knowing what those groups were. And only after the analysis is done is it unblinded and you can tell. The population here, this was 20 trauma centers and 39 EMS agencies across the United States and Canada. And they looked at data between 2015 and 2017. The entry criteria, remember they're looking for that Goldilocks. So it's patients that are adult-ish, meaning greater than 15, have some type of traumatic brain injury, and have a Glasgow less than 15. So they have to be hurt. That's the moderate part. But they can't have already herniated. And the way they looked for that was by pupils. So you had to have at least one reactive pupil to be included in the group. You also could not be hypotensive. Because we know hypotension is an independent predictor of mortality, no matter what you do with TXA and clots. So the 3 arms. Number 1, basically what I would call the traditional approach to TXA. 1 gram bolus in the field, followed by another gram over the next 8 hours in the hospital. Traditional approach. The second is a straight up 2 gram bolus, no more TXA. And then the third is a placebo. Now, to blind this so nobody knew what happened, we know that you have to get both a bolus and an infusion. So in the 2 gram bolus, you got a 2 gram bolus plus an infusion over the next 8 hours of placebo. In the placebo group, your bolus and your infusion were both placebo. Now, the comparison they did, and this is, I think, a little bit unfortunate, is they did not actually end up looking at 2 gram versus 1+1 versus placebo. They looked at any TXA versus no TXA. So that's an important thing to understand. Outcome, 6-month functional neurologic outcome. What did they find? So there were, if you look at the combined group, so any TXA versus placebo, there were 657 patients that got some TXA versus 309 who got none. The bottom line, there was no functional difference in neurologic outcome. There was no difference in mortality at 28 days. There was no difference in progression of intracranial hemorrhage. This is a negative study. What this is telling us is TXA does not work for patients with traumatic brain injury. But wait, not so fast there, Kemosabe. Let's take a look at those different treatment groups. So if you look at this figure, what you're seeing here is time after injury across the bottom and mortality. So the higher up you go, the more people have died in this group. And the colored range is just the 95% confidence interval for each of these three lines. And you'll notice there is a line at the bottom and then two lines that are essentially the same up at the top. And what we see here is even though the 95% confidence interval overlaps between the bottom and the top two, meaning no difference, there is one hell of a signal here that that bottom line has a better outcome than the top two lines. So what are the lines? The top two lines, that's placebo and the 1+1. The bottom line is the 2-gram bolus dose. So what this suggests to me, and I want to be very clear, this was a negative trial because you have to take the trial the way it was run and designed. But what this suggests to me is that in those patients with a Goldilocks TBI, maybe a 2-gram bolus would be better than placebo if you had enough numbers. So in other words, if you randomized it with sufficient power, you might see a difference. So I think this question is still yet to be determined. Now let's move on to epinephrine. If you have ever heard me talk before, I can almost guarantee you know my thoughts on epinephrine. The Paramedic II trial, oh boy, was that a clarifying event. Well, Paramedic II was a randomized controlled trial of epinephrine versus placebo in cardiac arrest, the trial we had been wanting for some time. So let's talk about the details of that real quick, and then we're going to look at the influence of time to epi administration on outcome in this trial. So what was Paramedic II? This was this randomized control trial, epi versus placebo in the UK, huge chunk of the British population, adult non-traumatic arrest, all comers, VFib, non-VFib, everybody's in there. They either got epi just the way we give it, 1 milligram, 1 to 10,000 every 3 to 5 minutes, or they got a placebo. The paramedics couldn't tell the difference. The doctors didn't know the difference. Double-blinded study just like the last one. So the net results of Paramedic II, their primary outcome, survival at 30 days, was better with epinephrine at 3.2% versus placebo at 2.4%. So epinephrine results in more people having a pulse at 30 days. But it turns out people don't care about having a pulse. They care about being able to wipe their own butt, not be in a nursing home, not pegged, not trached, being able to go back to work, not being a burden on their family. In other words, they cared about neurologically intact survival. And there was no statistical difference. Now, the interesting thing is let's take a look to reconcile these. There are more survivors, but no difference in neurologic outcome. That must mean that in the epinephrine group, in order to get more survivors, you had to have more neurologic devastation. And that's exactly what they found. So if you look at the survivors and compare their outcomes based on epinephrine or non-epinephrine, 31% of patients who got epinephrine were neurologically devastated. That's the trach and the peg and the butt thing. The placebo was 17.8% neurologic devastation. Almost twice as much neurologic devastation among survivors with epi than without. And my conclusion from this is epinephrine is saving the heart at the expense of the brain, something nobody wanted to sign up for. Now, there were lots of other things about that study, but I'm going to skip over those because I'm not talking about this study. I'm talking about the big thing people point to when they say it doesn't apply in the United States. The reason for that is the median time from 911 call, or what they call 999, to first epi was 21 minutes. And they said, too long, way too long. That's not what we do here in the United States. Therefore, I can't extrapolate from that to what we do, so we're just going to keep on doing the same thing we've always done. Well, here's the problem. First off, people hear 21 minutes time to epinephrine and they think time from arrival to epinephrine, but that's not what they measured. They measured time from 911 call to epinephrine, so response time is built in there. And then we think we give epinephrine way faster. So there is no published study yet that looks at this, but I will tell you that I did an unofficial analysis of ESO data set looking at hundreds of thousands of cardiac arrest, and I calculated this, and we are a little faster. Our median time to epinephrine 911 to first dose is around 16 to 17 minutes. All of the evidence says early epi is better, but they're comparing in under 10 minutes to over 10 minutes, and none of us are getting it in a median of under 10 minutes. So I'm not sure that matters. But the big question is, let's do a study and find out. So that's what this study did. This was a secondary analysis of Paramedic II, and they ran a model, a regression analysis between epinephrine and all the other things, epinephrine, age, witness to arrest, bystander CPR, initial rhythm, and outcome, but they threw in time to epinephrine. And guess what? No difference in survival. The time to epi is not what made the difference. Now, they did see what we would expect to see, which is the longer you're in arrest, the more likely you are to die. But they analyzed, after controlling for the other things, they analyzed the time to epinephrine, and that did not make a difference. My conclusion on this is it ain't the time to epinephrine. What they saw is relevant to us. We can't wiggle out of it. Let's talk red lights and sirens. This is one of my papers. Obviously, I'm passionate about this. The big question here, we know that we use lights and sirens to get to many of our EMS scene calls. We just don't know necessarily how often. The other thing we don't know, though, is does it matter? Why are we doing this? So the theory here, now the truth is the real reason we go lights and sirens to almost everything is because, one, it's fun, and two, that's what we've always done. Neither of those are good reasons to do it. We know a couple of things. We know from the paper my colleagues down in Austin did, Dr. Watanabe and Dr. Brown looked at the NEMSIS data set, and what they found is there is a higher odds of being in a collision running lights and sirens than not. Lights and sirens are how EMTs and paramedics are killed. Maybe we can decrease that. But the question is, we do know that lights and sirens saves between 1 and 4 minutes of response time. So what do we get for that 1 to 4 minutes? We know we're running an increased cost to get to the scene. That cost is the risk of collision and injury. But the question is it worth it? Our implication is, well, we're going to do life-saving stuff when we get there. So the question is, how often did we do that life-saving stuff? So that's what me and Von Hamilton and Mike Tagman and Lawrence Brown did. We took the ESO data set, and that's exactly what we calculated. What we found is that 86% of 911 calls use lights and sirens to get to the hospital. Now, I don't know what the right number is, but I'm pretty sure that's too high. Just a guess, though. We also, by the way, said, how often do we go to the hospital? That number is much less. That's only 13% of the time. But the big question is, what is the clinical yield? How often do we do something that is even potentially life-saving when we use lights and sirens? And the answer, less than 7% of the time. So 93% of the time we go woo-woo to the call, we don't do anything vaguely life-saving. And if you're honest with yourself, that probably matches your clinical experience also. So what do we do with this information? Well, our paper projected or suggested a methodology for safely reducing the use of red lights and sirens. I am not saying we should never use it, because I do think there are some circumstances where that 1 to 4 minute response time makes a difference. Cardiac arrest, for example. But how about we target our use of lights and sirens to how often we actually do something? So the methodology we do, and all the details are in this paper, we broke it down by call dispatch code. What was the nature of the dispatch? We can't decide whether to use lights and sirens or not to the scene based on what we find once we get to the scene. That's too late. The information we have is what our dispatchers have for us. So based on that, we have a different percentage. So for cardiac arrest, let's say it's 75%. For abdominal pain, say it's 0.2%. Let's set a threshold. And I think each community is probably going to be different. But let's say your community says, you know what? We think an appropriate threshold for risk mitigation, meaning the risk of running over grandma and hurting ourselves, is 5%. So if there is greater than a 5% odds of us doing paramedic stuff based on our previous history, then we'll run lights and sirens. But if it's under 5%, we won't run lights and sirens. Now, if you did that in this data set, that would lead to a 47% reduction in the use of lights and sirens. If your threshold was 10%, we calculated that would be a 62% reduction in the use of lights and sirens. I think those are meaningful reductions, and I think they will save people's lives. I think we should do that. That is low-hanging fruit, but let's do it in a reasonable approach, and I think I have given us a reasonable approach to doing this. So if y'all have ever heard me talk, you probably know that I love me some Airway papers, particularly VL papers. So here's another one that I really like. This was a study by Dr. Brown and his colleagues, and they looked at the NEAR Registry. That is the National Emergency Airway Registry. This is a registry of a lot of different emergency departments that all put in information about their airway management of patients, including the outcomes from patients. So we get a lot of great information from this registry. So this one was an analysis of this NEAR registry. There were 25 academic emergency departments included. They looked at all patients 14 or older between 2016 and 2017 who had an intubation attempt. And they compared two groups. Those who had unassisted video laryngoscopy. In other words, they used a VL, any flavor, CMAC, GlideScope, King Vision, any flavor of video, versus direct laryngoscopy that has been augmented. So ADL. Augmented direct laryngoscopy, and they include under the umbrella of augmented direct laryngoscopy things like DL plus the bougie, DL plus ramping, DL plus external laryngeal manipulation, DL plus some combination of those things. And then they compared first pass success between the unaugmented, unassisted, plain boring vanilla VL and each one of those augmented DLs. So overall, first pass success 90.9% with VL versus 81.1% with DL. So a couple things about this. First, if you have read the literature over the past several decades, what you'll notice is first pass success in the emergency department has been increasing. As an emergency physician, I think that's a great thing, good for us. VL has a higher first pass success than any flavor of augmented DL. Now, I'm a VL guy, so at this point I get to say, told you so. I think that's really it. I just want to say I told you so. So they did calculate, you know that there are some difficult airway characteristics. For example, you can be really big. You can have ankylosing spondylosis. You can have a bunch of gunk, hot dogs, beer in your airway. Well, those are definable airway characteristics, and it turns out they're reported in the NEAR registry. So they adjusted for all those things, and even after adjustment, odds ratio 2.8 for VL over DL, augmented DL. So that's 180% increased odds of first pass success using VL compared to any of the super DLs. Now, they also broke down VL by the shape of the blade. And I think if you've seen one video laryngoscope, you've probably just seen one video laryngoscope. They're really multiple devices lumped in together. You can say that a Mac blade DL is a Mac blade DL is a Mac blade DL, and that's probably true. Different VLs are fundamentally different, and the techniques are different. But you can break them down into two main groups, and that's hyperangulated geometry and standard geometry. And standard geometry is basically a Mac. So they compared hyperacute to augmented DL, still better, odds ratio of 3.2. They looked at standard geometry, so video MAC versus regular MAC, or probably some Miller's thrown in there. 2.4 odds ratio. All of these are statistically significant. So what we see here is that if you care about first pass success, and I think there's a lot of literature saying you should, VL on the whole results in higher first pass success. Now, I will say this is different than the information we've seen in prior emergency department studies from 5, 10, 15 years ago. And I think this is probably a function of when video laryngoscopes first came out. The one that came out was the GlideScope, which is the classic hyperacute angled blade. The techniques you use with a hyperacute angled blade are dramatically different than DL. Once you understand that, you see things like this study shows us, you see better first pass success rates. But until you understand that, until you get used to it, if all your experience is with DL, you're probably going to be worse with VL. And the early studies looking at VL versus DL showed either worse or no difference in success. And as the years have gone by, as we've gotten more experience with VL, you've seen first pass success increase, and now it has surpassed DL. Here's a question for you. There you are, you're working your arrest, and you need access. You got to give some life-saving medications. You got an IV catheter and you got a drill. Which should you use? Well, the drill's certainly easier. It's faster. Why don't we just do that? IVs in patients with no palpable pulses, that's kind of hard. Let's just drill them. Well, and I think we have seen that probably the majority of cardiac arrest in the field now get an IO right off the bat. Maybe that's good, maybe it's bad. How do we tell? What is the outcome we should really care about? Is it speed to access? Patients aren't dying or surviving based on how rapidly we get the needle in the arm. But maybe they are living or dying differently based on what type of needle it is. So that's the question. We got a couple of papers to look at with this. So this is a secondary analysis of Paramedic II, and as you remember, Paramedic II is about epinephrine. So what they did is they looked at the survival with epi versus placebo, but they did it based on just those who had epi given via IV and just those who got it given via IO. And what they found is for survival at 30 days, remember the parent study overall showed improved survival. They see improved survival with IV but not IO. So they're seeing an impact with IV but not with IO. How about ROSC at hospital turnover? They see more ROSC at hospital turnover regardless of the device. Neurologically intact survival, no difference with either IV or IO. So there is a hint here. This isn't really strong data, but there's a hint that IV may be better than IO. But let's talk about antiarrhythmics. So this is data from a secondary analysis of the ALPS trial. The ALPS trial was not actually a wilderness medicine study. Instead, it was a study of amiodarone versus lidocaine versus placebo in shockable rhythm out of hospital cardiac arrest in adults. Now, they looked at amiodarone and compared it to lidocaine and placebo, and what they found was no difference. And this was, pardon the phrase here, there's a dad joke, this was a shocking result. Get it? Shocking. Shockable rhythm, shocking. It's a rough crowd. All right, so we were surprised. How's that? We were surprised by that. So we've been kind of looking, why is that we're not seeing results? So this secondary analysis went in, looked at that data, and performed the same evaluation, amio versus lidocaine versus placebo, in just those who got an IV and in just those who got the drug via IO. Let's look first at amiodarone. And what we find here is survival to hospital admission is significantly higher with amiodarone when given via IV, and there's no difference with it when given IO. If you look at survival to hospital discharge, higher with amiodarone than placebo when given IV, no difference when given IO. But Jeff, you've been saying all along what you care about is neurologically intact survival, so what if survival is higher? It turns out amiodarone compared to placebo when given IV improved neurologic outcome when given IO? No difference. Well, lidocaine was involved in this thing too, right? So let's look at lidocaine versus placebo. And what we find is almost the same thing. So survival to hospital admission, higher with lidocaine in an IV, no difference with lidocaine in an IO. Survival to hospital discharge, higher with lidocaine in an IV, no difference with lidocaine in an IO. That's exactly what we saw with amiodarone, but the difference here is that neurologically intact survival, no difference when given either IV or IO. So this is one additional piece of information that suggests maybe the route does matter. So why would it matter, you ask? Well, we know most IOs, at least when this study was done, were proximal tibia IOs. We know that the flow from a humeral head IO is higher than the flow from proximal tibia, and presumably from a distal femur too. We know flow is higher in the humeral head. It gets to the central circulation faster. Maybe that's what the difference is. Maybe it's a function of lower extremity versus upper extremity. Most IVs are in the antecubital fossa. So maybe the circulation coming up and going through the liver in the lower extremity, maybe that's what's making the difference. Bottom line, we don't know. We have some pretty strong signals right now that IV is better than IO. It's not definitive, but some signals. An interesting question, one you probably are asking right now, is, well, is humeral head better than tibial? And is humeral head any different than IV? I don't know. I will tell you we're looking at that in a data set. Maybe we'll get some interesting results, but nothing as of right now. So let's talk ketamine, shall we? We know that there was a brouhaha in Colorado about ketamine use for agitated patients. But as of yesterday, I saw some rather disturbing news that some additional police officers and 2 paramedics were criminally charged. Presumably, the criminal charge against the paramedics has to do with ketamine. So we know that some of the accusations that have been made against ketamine don't ring true to us. Some of the accusations are that the police are giving it to assist in arrest and getting people to jail. We hear that police are telling paramedics to give it. We hear that they are giving it to all agitated patients. We're hearing that that's the only thing ketamine is used for, is agitation. We hear that it's being given in massive, massive doses. We hear there's no monitoring and that these patients aren't ultimately going to the hospital. Now, I don't know about y'all, but that's not been my experience. When I'm in the field, that's not what we do. When I'm reviewing records, that's not what I see in the records. And when I talk to my medics, that's not what they're telling me they're doing, which is good because those would all be bad things. I think we would all agree with that. What we need here is a large national data set of 911 ambulance calls that we can evaluate that. Now, fortunately, there is such a thing. It's the ESO data set. So this is, obviously, you know who ESO are. They're a large EPCR vendor, but they make anonymous data available for research purposes. ESO also turns out to hire some really bright researchers. So Doctors Tony Fernandez and Rimley Crow are research scientists that work for ESO. Dr. Scott Bourne also works with ESO. He is also a researcher with an interest in this. And then there are some board-certified emergency and EMS physicians, dual boarded. If you are going to pick someone who is an expert in the pre-hospital use of ketamine, you would pick someone with dual certification, board certified in EMS, board certified in emergency medicine. Well, doctors Brent Meyer, Ken Shepke, Peter Antevi, so including a pediatrician, and Dr. Stein Bronsky, all worked on this paper. And they looked at that ESO data set and they said, let's describe how ketamine is actually being used. So they had 15,000 doses of ketamine in this data set given to 11,000 patients by 458 agencies. That's a lot of ketamine, folks. So first off, Number one accusation, we're giving it, not taking patients to the hospital. Not a shock, but in this data set, 99.4% of patients who received ketamine went to the hospital. What about that 0.6? Did they go to jail? Well, they didn't specifically look, but remember, this study is looking at all ketamine administrations. And I know in my system, we have given ketamine in cardiac arrest because of awareness during cardiac arrest, and some of those arrests don't turn out so well and we terminate in the field. In my system, we also use it for pain in subdissociative doses where they never lose consciousness, and perhaps they still have capacity to refuse care. Bottom line, we don't know, but we do know overwhelming majority of patients went to the hospital. Now, the cool thing here is that 18% of these patients that got ketamine actually have hospital outcome information as part of the ESO dataset. And they were able to look for mortality, meaning death. All these patients were giving ketamine to, how many died? Well, it turns out in this dataset, only 6.4% of patients who got ketamine died. You're like, oh my God, 6.4% of patients died because they got ketamine. That is not what I said. I said of patients who got ketamine, 6.4% died, but let's be honest, there's probably a reason they got ketamine. Well, what was the reasons? Well, it turns out the majority reason, the number one reason to get ketamine was trauma or pain management. It was not agitation. So we're giving it because they're horribly mangled, and being horribly mangled may increase your odds of death. Another really, really big reason for giving ketamine was for cardiac or pulmonary reasons. So we use it for CPR, like I mentioned, but we also use it for intubation. We don't intubate healthy people, and we certainly don't do CPR on healthy people. So perhaps the reason they died was because they were really sick, and that's why we gave them ketamine. But it does bring up a question. Maybe how many of these deaths were from ketamine? So the methodology they had here is those 4 physicians, remember, all board certified in emergency medicine and in emergency medical services, went through and reviewed the narrative and the hospital information meaning outcomes, on each one of the patients who died. And they said, can we exclude ketamine as a cause of this death? And they were unbelievably conservative with this. So as an example, they had someone in a car crash who was unconscious on arrival and hypotensive. They were given ketamine for airway management, at least presumed for airway management, transported to the hospital, no more ketamine. Several days later, they died. They gave ketamine. Several days later, ketamine ain't around after a few hours, but several days later, with no additional ketamine, they died. They said they could not exclude that as a cause of death. So that was how cautious they were in excluding ketamine as a cause of death. Very, very conservative. And what they found, there were only 0.2% of deaths that they could not exclude ketamine as the cause of death on. In other words, that's not why they're dying. So that is good information. That's telling us that ketamine is not rampantly killing people. But we're not monitoring them. No, it turns out 95% of patients had pulse oximetry on. I will tell you, it is a little concerning that only 68% of patients had end-tidal CO2 on. So I think we should, as a profession, do a better job of monitoring with end-tidal CO2. It is a much faster indicator of respiratory depression than pulse oximetry. Please do me a favor, if you give ketamine, no matter what the dose, put them on end-tidal CO2. Is ketamine effective? Well, let's talk about one indication of ketamine, as that is agitation control. So why use ketamine? Because there are so many better alternatives out there. There's haloperidol, for example. There is midazolam, for example. Why aren't we just using haloperidol or midazolam? Good question. Now, if you've used those drugs, you know they take a while. And if you have ever been, and I suspect you have, in the back of an ambulance by yourself with a highly agitated patient, I don't know about you, but when I was in that situation, I didn't like getting my butt kicked. I didn't want to go for 20 minutes of getting my butt kicked. But if we can give them a medication that can safely control their agitation more rapidly, maybe that's a good thing. That is the question that this study looked at. This is the RACT trial. And I have to tell you, Dr. Barbic, points to you for coming up with this title. RACT stands for Rapid Agitation Control with Ketamine in the Emergency Department. Strong work. That is a great name. I'm going to use that as often as I can. This is an emergency department-based randomized control trial looking at how long it takes to get adequate sedation of patients who are agitated and in need of sedation. So these are undifferentiated agitation, and I think that's important. When you talk to psychiatrists, they will talk to you about, we don't need ketamine, we can use these other medications. Let's be very clear. The patients they are seeing are different than the patients we're seeing in the emergency department. If you're a psychiatrist, first off, you probably do not ever see patients in the emergency department, but if you do, you see them after the ER doc or the medics have already sedated them. It's a different population. So single center emergency department, undifferentiated agitation, that means drunk people, stoned people, methed people, and psychiatric people. It means all of these patients lumped together. They randomized them to get either 5 milligrams per kilogram IM ketamine or haloperidol 5 plus midazolam 5. So 5 per of ketamine versus 5 and 5 haloperidol Versed. Randomized them, boom, boom. Their primary outcome was time to adequate control. So a little piece of information here. What is it? How did they define this? How did they make it objective? They used the RASS score. RASS is the Richmond Agitation Sedation Score. If you're using ketamine in the field for agitation, you should use some type of objective measure. We use RASS. I think RASS is a great one. In order to get into this study, you had to have a RASS greater than 3. The score goes up to 4. So a RASS greater than 3. Adequate sedation was a RASS of -1 or less. Primary outcome, time to control. All right, so let's take a look at what they found. There were 40 patients in the ketamine group, 40 patients in the haloperidol versus midazolam group. Now, one question is, why so few patients? The reason, you got it. This was published in 2021. What do you think the answer was? COVID. They had to shut down enrollment because of COVID. So COVID ate everything between 2020 and 2021. Y'all know that. We know that. Unfortunately, it ate the second half of this trial. But what was the bottom line? Did they have enough patients to show significance? They did. What they saw is that with ketamine, it took them 5.8 minutes to get adequate sedation versus 14.7 minutes with haloperidol midazolam. That is an 8.8 minute, almost 9-minute difference. It takes another 9 minutes to get control with haloperidol Versed versus ketamine. That's an important 8 minutes. They calculated a hazard ratio for this and came up with an answer of 2.43-fold improved time to sedation with ketamine versus haloperidol and midazolam. Serious effects. Well, hey, you're probably causing lots of patients with ketamine to get intubated. I know I've had ER doctors tell me, well, I didn't have a choice. Your medics gave him ketamine and I had to intubate him. Arm behind the back and everything, had to intubate him. So you would expect in this group randomized to ketamine way more intubations. Guess what? No difference. Oh, how many? None. No patients in either group needed intubating. No difference in serious adverse events. So what we see here is that ketamine was safe and it was effective and it was faster than haloperidol and midazolam. And the last thing I'm going to say about this is they didn't muck around giving the Haldol. They didn't give 2.5 a Haldol. They didn't give 5 a Haldol and then wait and see if they needed Versed. They gave 5 and 5, which I think is a very reasonable dose. This graph is a Kaplan-Meier plot, and basically it's looking at the percent of patients who had adequate sedation at any given point in time. The upper line is ketamine, the bottom line haloperidol and midazolam, and you can see crystal clear difference there. Ketamine just worked faster. All right, let's finish up with the thing that has, again, eaten our entire year and a half, and that's COVID. Let's take a look at the data behind the vaccine. I'm going to do this really quickly because I think you know this, but there are some images in these studies that I think will be really, really helpful. So this is the study from Pfizer. It turns out the study from Moderna was almost identical, different words, same slide, same results. What we know about this is it was a multinational, double-blind, placebo-controlled, randomized controlled trial. They included adults. Remember, this was Pfizer, so 16 and over versus the 18 and over with the Moderna. They excluded you if you had prior COVID or if you had an active illness, or I think, as we all know by now, if you were pregnant. They looked at 30 mics of mRNA vaccine given in 2 shots 21 days apart. They compared it to saline given exactly the same way. Their primary outcome was, as the FDA mandated, by the way, safety. So they were comparing adverse events, both local and systemic, and efficacy. And they were looking for symptomatic COVID, so positive PCR and symptoms, at least 14 days after the second shot. So the kind of results you want when you do a study, you want the results to be so good you don't have to do statistics. You want things that are so good you just show the picture and it gives you the result. So XKCD, I love his comics. He does some science-based comics, great stuff. Look him up. He also has some great books on explainers. Great stuff. He's a funny guy. This is showing a hypothetical thing. I mean, there's no way the data could actually be this good. But this is what we want to see, right? This is our goal, where the placebo group keeps getting more and more COVID cases, just going straight up. But the vaccine group is flat, no difference. That would be amazing, but we know that there's no way that would actually happen. Let's look at what the real data showed. That looks pretty much like this is amazing data, y'all. These were amazingly effective. So highly efficacious, and we know local systemic effects. I hear that there's a lot of stuff going on right now about how sick people are getting. The vaccine is killing people. I am an ER doctor. I see patients in the emergency department. I know who's in our hospitals. Our hospitals right now are overflowing with unvaccinated patients with COVID. They are not overflowing with vaccinated people with side effects. As a matter of fact, I have seen like 2 people that have a side effect from a vaccine and they had some redness. They had a little pain. I've never admitted a patient with an adverse event from a vaccine. Now, they can happen, but that's not what's killing our hospitals right now. These are safe and they're effective. Well, that was a trial, right? And by the way, there were 40,000 patients in this group, 20,000 in each arm. Well, what about in a real-world situation? Well, this was a study with the Pfizer vaccine in Israel, and basically they said, let's take a look at vaccinated healthcare workers and compare them to unvaccinated healthcare workers, and we're going to do a matched comparison. We're going to match them based on age and comorbidities and all the other things. And we're looking at really big numbers. Almost 600,000 people, 596,000 people who got the vaccine and 596,000 similar matched pairs. And they wanted to look for the things. They wanted to look for any documented infection, symptomatic infection, hospital admission, severe COVID, and death. And what they found is the graph for each one of these outcomes looks about the same as the original trial. Remarkably effective at preventing severe COVID, any symptomatic COVID, hospitalizations, and death. Now, they couldn't actually calculate the death because there were none. And when you put a 0 into these models, they blow up. So that is very reassuring. The thing this added was we had never seen an impact on asymptomatic infection, and it turns out it lowered that a lot too. All right, that is all I have for you. Those are my top papers from 2020 and 2021. I think there are some potential practice changers in here. Guys, if y'all have any questions about any of these papers, if you want a copy of these papers, if you want to talk about some of these papers, or if you just have questions about, say, vaccination, let me know. I want to give you information about it. You can reach me, jjarvis@wilco.org, or on Twitter @Dr. Jeff Jarvis. Thanks a lot, y'all.